Great pleasure to present a TEER case in a tricuspid valve. Okay, so this is an 82-year-old female patient with known COPD on inhalers. Patient had 2 hospitalizations within the last year with symptoms of right-sided heart failure, fluid overload requiring IV diuretics, NYHA class 4 by definition, atrial fibrillation, hypertension, previous TIA, diabetes on tablets, and some renal impairment. So for this, the Euroscore 2, if you calculate, is not huge, but it's in the moderate to severe scale, 4.4. But the tri-score is significant, and this is a more specific valve-specific score that we use in order to estimate the risk of having a tricuspid replacement surgically. Echo values, ejection fraction of the left ventricle within normal range or low normal, aortic valve is okay, mitral valve mild MR, and of course tricuspid valve you will see dilated annulus in complete central coaptation. And also severe pulmonary hypertension. These are the values from the right heart catheterization. You can see that the wedge pressure is 22, so it's not that high, but systolic pulmonary pressure is quite elevated. Without a lot of elevation on the pulmonary vascular resistance, cardiac index is somewhere reduced, but not severely so. And the filling pressures on the right side are elevated with a V wave of 25. That is consistent with severe tricuspid regurgitation. No coronary disease, and pro-BNP quite elevated too. And I just have the transgastric view here because I wanted to focus on the technical stuff. So this is a quadricuspid valve. You can see here that you have, I don't know if that works, but you can see that there's a split anterior leaflet okay, that works. Split anterior leaflet. You can see that there's an anterior portion and a mid portion, a septal leaflet and a posterior leaflet. So, but there is a quite significant coaptation, so there's no a huge gap. And we were quite happy that this is a valve that is doable. No leads, no tenting of the leaflets, as you will see on the images. So we attempted a TEER procedure. The quadricuspid might be an issue when it comes to repairing the valve. So this is how we do the procedure, direct femoral access percutaneous, like with most clip procedures, puncture with ultrasound, insertion of a stiff guide wire to the SVC, and then introduction of the steerable guide catheter. You can see removal of the dilator here with some aspiration, and then we will introduce the delivery system. You can see on the top right also the images of the valve. While we're doing all this, of course, the imager has to follow the position of the guide catheter. You can see there that the guide catheter is actually inserted. We need to make sure that it doesn't impinge on sensitive structures such as the atrial septum, because most of the IVC trajectory tends to send the valve, assembly to the interatrial septum. So this is now introduction of the tri-clip. XTW, the biggest size. This is 99% of the cases, this is what we use. And we want to just advance it a little bit further, steer away from the septum using the L knob on the guide catheter, and then achieving a straddling position. You can see that on the fluoroscopy here. And the next step will be to flex it down to the tricuspid valve. So we flex it. This is all in real time, so it's pretty fast, using the F function. And then we just want to achieve a position above the region of interest on the echo. So you can see that the clip now is above the tricuspid valve. We can see it on the biplane view, assess the trajectory on the long axis, make sure that we're coming parallel to the long axis of the RV, and also above the area of interest, which is where the collar is. And we should be able to see the collar. Very fast, we open the arms of the clip, and we assess the independent grasping feature. So right now we will drop one of the grippers, and as you saw, this was the septal gripper. So we know that if we want to capture independently, the septal is the one that has the marker on. And this is the region of interest. You can see that the clip is above the collar. So we're in the zone that we're interested to grasp, and now the main thing is to look at our orientation, the perpendicularity. The way to do that is get the clip above the leaflets, and then go to the transgastric view that you saw before. So our aim was to get a clip in the anterior part of the valve, and then move to more centrally to the second scallop of the anterior leaflet. We were happy that the orientation was okay. Then we close the clip, we move into the ventricle with the clip closed. So this is, we close the clip and we move in. We just want to make sure that we don't go too deep because there are dense cords. Tricuspid valve has got lots of cords, so we don't want to get caught in the cords because that can create some issues there. We're happy now, we're moving in, and then just below the leaflets, we will open the clip and we will try to come up again to confirm the leaflet insertion. We can fix our orientation on fluoroscopy. So on fluoro, we see that the leaflet, the discs, the arms of the clip are not seen as open, they're seen as a single line, but we confirm the orientation on the transgastric view, so we can see that we're perpendicular to the line of coaptation of the anterior and the septal leaflet in the anterior part of the valve. So once we're happy with the orientation, then this is leaflet grasping. We try to go for simultaneous grasping, so you can see on the top right that both the anterior and the septal leaflets are nicely flat on top of the arms of the clip. And if we're happy with they're relatively mobile, we will drop the grippers in a minute. Then we'll close the clip, we will lock. We'll just push down the handle, and this is the first grasping on first attempt. We try to do as little attempts as possible because there is always the potential of pulling the leaflets and creating some damage. Tricuspid leaflets are thinner than mitral leaflets, so we don't want to mess around with it. And then transgastric is always very important to ensure that the leaflets are nicely inserted inside the clip. So you can see now both the septal and the anterior leaflets there are actually curving inside the clip. And we always assess the leaflet insertion. So we have recorded all this, and we look at the leaflets, how they get in. So the interventional cardiologists have to be really patient. You can see I've got my arms crossed there. I'm waiting for Elias to do all this job. If you rush him, it's a recipe for disaster. Sometimes we've done this in the past, and you know, I think we have to commend all the imagers that are actually doing this job to be patient with the interventional cardiologist. But really, the story of success depends on the accurate imaging, ensure that enough leaflet tissue has gone in, that while closing the clip, no leaflet has escaped. And once we're happy with all this assessment, then we're good to go and release the clip. I will remind everyone, with a triluminate initial experience, the single leaflet detachment was up to 7%. Of course, BRI that had more advanced operators and more use of XTW, this went down to 3.5%. We tried to eliminate that as much as possible. So this is now deployment of the first clip. You can see now, we just released it and we took it out. And the clip is still in position. We always look on fluoroscopy if it's stable, and also on echo. And you can see that there, in the posterior part of the valve, there is a residual jet that comes from the central part of the tricuspid valve, the second leaflet. And this is something that we will confirm in a minute on the transgastric view. So second clip is inserted. This will be put more posterior to the original clip. So that means on the fluoro, it will come just below it. So we have the fluoro position of the first clip, so all we have to do is just by looking at the echo, follow the same steps, go for straddling, flex down to the valve, having the first clip as a marker, so that usually doesn't take too long. It takes a few seconds to go down. You will see that in real time here. So this is second clip going in, and always looking at it on echo, and then it will flex down in a minute. I can accelerate it a little bit more. So we pretty much follow the same steps. So you see second clip now is above the region of interest. And in a minute, we will open the clip like before. Septal arm is still independent grasping as before. And then we assess it on the transgastric. This is really critical. So what we want is to be in the region of interest, so the posterior scallop of the anterior leaflet, but we want to rotate it a little bit clockwise so that we're perpendicular to the line of coaptation. So if you look, the second clip is a little bit rotated with respect to the first one. First is single line. On the same view, this is a little bit rotated. So it's very interesting to have these fluoro-echo correlations. So you see now we're rotating clockwise, and we achieve a perpendicular position in this central aspect of the valve. And once we achieve that, then we are good to go in the valve as before. So we see we close the clip, we go inside the ventricle, just below the leaflets. And now we leave the leaflets to go in. There was a little bit more distance here, so we selected to first grasp the anterior leaflet, the lateral, which is the anterior leaflet, you will see in a minute. We'll just rotate, swing a little bit lateral here. The anterior leaflet is going in. Once we're happy that it's flat and relatively mobile, we drop the gripper right now, and then we can rotate clockwise to the septal part of the valve. So see, and now septal leaflet is coming in. So imaging has to be very precise, very stable. No rush. So septal now is in, and we're just closing the leaflet, the clip. Just make sure we don't have tension. So independent grasping on this central position, but you can see the contrast now on the right atrium here, which is a good sign. That means that the backflow has been eliminated, and voila, practically elimination of the tricuspid regurgitation, which is good. Again, we follow the same laborious process of ensuring that we have the leaflets correct, that enough leaflet has been inserted. And you will see here on the transgastric view that we want to make sure that the leaflets are curving in on the central clip, on the posterior clip. So you can see both the lateral, the anterior leaflet, as well as the septal leaflet are going in. So this is something that we have to do. And once we're happy with all these checks, we also look at the recordings. Here is the final leaflet position. Then we're happy and we release the clip. So clip is released now. And as you can see on the fluoro, the clips are stable. They're moving pretty much together. No rotations, no rocking motions, very important. And also on the transgastric views, we see the same position, the same curving in on the leaflet. And this is the immediate outcome after the case. You can see just trivial tricuspid regurgitation, mostly in between the clips from this little cleft at the anterior leaflet. You can see how stable the leaflets are on the anterior clip and the posterior clip. Actually, patient did very well. This is the safety and the efficacy of having a TEER procedure. Patient has been followed up to 15 months now. She's doing quite well. She hasn't been in the hospital, having good quality of life, no more hospitalization. Thank you very much for your attention.
That was like a Evoque-like result. Very good. Isn't that, Costa, Evoque-like result? I don't know if the quadrileaflet valve helped out to have a better result than the average trileaflet valve, because it's a little bit more square and the grasp, I think, better than this trileaflet valve. Is a little tricky, try to grasp together. We may need a little bit different configurations, I would say. This seemed to be a little bit more symmetric. So that was a great demonstration.
Usually quadrileaflets, tricuspid valves are disadvantaged because you've got more clefts and the potential to open them. I think the key here was that we have very good imaging. We have enough leaflet length and elasticity, so we didn't have tenting, we didn't have a massively dilated annulus, big coaptation gaps, but most of it, the imaging was superb.
Did you have eyes? No eyes.
We had the eyes of Elias Ninios,
not yet.
so not eyes.
You had also a great approach to the ventricle.
Exactly. Trajectory was very good.
The trajectory is perfect. This is one of the most important parts in this procedure. Yeah. If you get me the weird trajectory,
The excessive septal hugging is a problem.
Right.
You have to use a lot of L, and then you're rotating.
So I think that
and
before the tri-clip, we would do these procedures with the mitral clip device. And whenever you came as a septal hugger, you could not really get in a good position to the ventricle. The tri-clip with the S and L knob allow us a better approach to the ventricle and make this procedure much, much more easier.
Agree 100%.
Blasi, great job as always. Do we really need the residual tricuspid regurgitation because we've got this sort of right ventricular dysfunction?
I wasn't expecting any more difficult question than that. The answer is I don't know. If we look at the paradigm from the mitral, when we started doing these clips many years back, I mean, Moni Kostas knows all this, we were aiming for a 2+ residual MR. We were happy. Now we've learned the hard way that 2+ is not enough because there's a potential for recurrence. Now, tricuspid regurgitation, we're happy with moderate or less, according to the outcomes of the Triluminate, for example, the BRIDE registry. But having said that, EVOQUE eliminates it. So, you know, what is the optimal? We don't know. Clinically, patients get better, but what happens midterm, long term? My guess is that we need less than moderate in tricuspid too. But we have to customize it to the individual patient. So if you have a massively dilated RV with an impaired function, it's a problem. Afterload mismatch is a reality, and you cannot do much about it. RV you cannot support. LV you can do lots of stuff, but RV you cannot support. But
as Costa recommended, the valve is implanted in a very good right ventricle.
exactly.
I like the comment of George about EVOQUE-like result. It's like surgical-like result. Congratulations to the Ninios company. Great result. I think I would definitely also go for TEER in this patient.
Yeah.
I didn't see any sign of I would have low possibility to get a good result. Simple question. Do you think the first clip was necessary because it went to an area that there was no color? Do you think you will get the same result by just going in exactly the source that was in the center?
Good question. I don't know, but I always feel insecure with tricuspids of going with one clip, especially when there are multi-lobes. I think you get because patient was sedated. I didn't have access to the original transthoracic echo pictures when the patient was awake. The color jet was a lot wider, so the true nature of the tricuspid regurgitation was underestimated on the patient's sedation. Also, the patient was optimized. So really, we don't see the real picture. When we scanned the patient a couple of months before on acute decompensation, the jet was wide coming from all over the places. So I think that if we hadn't put the anterior clip, we would probably had an area that potentially we would have a residual tricuspid regurgitation. But that's a guess.
Because I moved to that concept lately, I would like to ask Michael, who is there, how he judges our results lately. Because in most cases, when I see the pathologist in the center, I directly go with one clip Pascal in the center. So, Michael, how do you see this approach that we're doing lately?
Yeah, we usually start off in the septal anterior area of the valve. It's a classic, but I think more or less in the past few cases we moved on to more directly targeting the center of the regurgitant jet. Also, would like to point out that this is atrial functional TEER. So atrial functional seems to be very amenable to edge-to-edge repair. The leaflets are closer together, less coaptation gaps. So it's ideally suited for edge-to-edge repair. Very nice case.
Yeah, this is a Triluminate case. I mean, typical.
And it's very important to remember that sometimes the jet that you get in the procedure is different than the screening one, especially in the tricuspid, because there's a lot of variation. And I agree, I prefer to put two, anteroceptor, another one. There's also an impact of, I'm not sure that in this case, but there is also an annuloplasty effect. When you get two clips there, you decrease also the annulus, and I also prefer two clips if available, if needed.
I agree.
So I think that we'll conclude this session, and I am the bad guy that said that there is no break. So we'll go directly to our next session of hot topics in the mitral valve